CAD, this is now an arterial problem, but particularly we'll talk about the coronary arteries. Of course, when the patient has the risk factors, doesn't mean that only the coronary arteries are affected here. All the arteries in the body are. But for chapter 23, this will just deal with coronary artery problem. So when you have CAD, then you are at risk for acute coronary syndromes, okay? Plus the fact that you developed it, that means, do you have the risk factors for atherosclerosis? Yeah. Yes. So let's go to the risk factors for CAD. So this is the number one, or the root cause. It's really atherosclerosis. Now, what does arteriosclerosis mean? It's the same hardening, right? Hardening or narrowing of the arteries. But atherosclerosis is one form of arteriosclerosis. So this one is the deposit of plaque in the arteries, particularly in the coronary artery in this particular scenario. Keep in mind that the plaque is not on top of the endothelium, right? What I'm trying to say is, if this is your artery, okay, so the innermost lining here where the blood flows, this is called the endothelium, correct? And then we have the intima layer, then the muscle layer, and then of course the tunica externa, right? The wall of the artery. The plaque is in between the endothelial and the intima layer. It's not on top. So it's not like your teeth wherein you have plaque there, you can scrape it off. No, you can't scrape this off because this is growing in between the inner and the middle layer of the artery. So how did it get there? Well, you have risk factors, high cholesterol, number one, say smoking, you have uncontrolled diabetes, because what will your body do with excess sugar? Turn it into fat. And then where will it throw it? First to the liver, but then when the liver is full of fat already, where else will it throw it? Anywhere. So anywhere in your love handles and your hips, but then nowhere else to throw it. They'll throw it into the arteries, okay, the walls of the arteries. So now you have atherosclerosis. So now over years, your coronary arteries, one or more of them, are containing plaque. So you have coronary atherosclerosis now. So how did you get there again? So you have risk factors, namely diabetes again. What is metabolic syndrome again? What are the 4 conditions that diagnose you with metabolic syndrome? Diabetes, hypertension, high cholesterol, and abdominal obesity. Okay, so those are the 4. So if you have those 4, you have metabolic syndrome. Okay. So here's the illustration again where the plaque forms. The problem here is when the bigger the plaque accumulation, then the weaker the artery becomes, because look at the integrity of the wall now. It's supposed, the intima layer, the endothelial layer is supposed to be stuck to the muscle like this. The more plaque you put in there, look what happens to the endothelial layer. It's now pushed up, right? It's now separated from the intima layer. So now what happens to the integrity? It weakens it. And what happens to blood pressure? The narrower the artery becomes. And then what will the high blood pressure do to the weakened endothelium? It will rupture it. Okay, so here, look at now. This is now more than 50% atherosclerosis. So now the lumen of the artery is so narrow that increases afterload, correct? Pressure increases, then the higher the pressure, then the more likely it will rupture the endothelium. And then once this ruptures, now the integrity is no longer smooth. What will platelets do? They'll stick to it. One platelet sticks, another and another. Then after that really big orgy of platelets, then you have a blood clot. Then it's called a heart attack now. It's actually not a heater. That's a...
It's hot. Let's go.
So here are your coronary arteries. Depends on which coronary artery is worse, which one has the worst case of atherosclerosis will determine the area of heart attack. So get to know you don't have to memorize, but just be familiar with which coronary arteries supply which part of your myocardium. For instance, if I ask you, which one supplies the left ventricle? The left anterior descending artery, so the LAD. So if somebody has a heart attack there, will they survive? This is the left ventricle that it supplies. So if that thing gets blocked, you're not likely to survive. Okay, so you're dead. The RCA, okay, the right coronary artery, you have a higher chance of surviving that one because that's supplying the right side, correct? And the ventral aspect still on the right side. And then this is the posterior part. So you have here the back side of the right ventricle. So these are the right circumflex. Okay. Then the left circumflex. So it just depends really. Your outcome, your prognosis depends on which coronary artery was blocked. Manifestations. There are 3 acute coronary syndromes. They are chronic stable angina. No, sorry. Chronic stable angina is not acute coronary syndrome. So the 3 are unstable angina. Second is the NSTEMI or non-ST elevation MI. And then the third is ST elevation MI. Those are the 3 acute coronary syndromes. But before we get there, let's do the non-ACS first. This is equivalent to, you still remember peripheral artery disease from MedSurg 1? Yes. There were stages, correct? So how do you describe stage 1, stage 2, stage 3, stage 4? Stage 1, did the patient have any symptoms? No, right? They were fine. They didn't have any leg pain. Stage 2, what was the characteristic of stage 2? There was intermittent claudication, correct? What does intermittent claudication mean? How is that described? When you walk, it hurts, right? The leg hurts when you walk. And then what happens to the pain when they are forced to stop, sit down, or lie down? The pain goes away. Very good. So that's stage 2 peripheral artery disease. This is the equivalent. So if that artery, stage 2 PAD, is now in the coronary artery, this is the equivalent. All right. So when you have angina pectoris, or also called chronic stable angina, this is like stage 2 of PAD. This just happens to be the coronary artery. In PAD, it was a peripheral artery, right? Popliteal or the femoral artery or whichever peripheral artery. So that was stage 2. This is the equivalent. So here, what happened to the artery? It has atherosclerotic plaque. The patient has coronary artery disease. Here, though, the narrowing of the artery isn't enough to cause a heart attack. Okay, right? Not yet. Now, ischemia, the pain only comes in with increased oxygen demand, which if this is now narrowed, if this is your coronary artery, and it is now 40% blocked, if you have any activity that increases the heart rate, which means what happened to your oxygen demand? What were you doing? Why did your heart rate increase? Could be, walking, running, right? Could it also, does it have to be physical exertion that will increase your heart rate? Can it also be a severe emotional event? Say you're so happy, right? You won the lottery, or you got divorced. Some people will be happy with that, right? So anything that will increase your heart rate, either physical or emotional event preceding the episode, causing imbalance in oxygen supply and demand. Therefore, it will cause ischemia, correct? Meaning your heart is demanding more oxygen because it's beating faster. But then the artery is narrowed. So can that 40% or more narrowed artery supply the increased requirement? No. So it produces ischemia. So now the patient has chest pain. All right. Usually there's no other symptom and it's reproducible. The patient learns this over time. Yeah, the last time I mowed the lawn, shoveled snow, I had chest pain. Right. And then also when I was climbing the stairs, I had chest pain. But then when I stopped, the pain went away. Okay. So just like intermittent claudication. There's always a precipitating event though. Meaning once this patient, let's say, goes to the doctor, and of course the doctor will run tests. Okay, let's check you out. Let's check your cholesterol. Let's check your your echo. Okay, so they'll do an echocardiogram. They look at, okay, how bad are your heart? Okay, what does it look like? And then they'll do stress tests. Okay, examine, how the heart can take, stress, and how much can it take, and then you get a diagnosis of coronary artery disease. But because of your chest pain episodes, and they'll ask, what happened? What were you doing when the chest pain started? So they usually say, oh, I was having a fight with my wife, or I was really excited, or it happened during sex. Okay, I was having sex with my wife and then had chest pain. Okay, so there's always a precipitating event. Risk factors, again, I already described metabolic syndrome. So we add now other risk factors, which is smoking. So we add there. So here's metabolic syndrome. So here are the 4 again characteristics of metabolic syndrome. For abdominal obesity, the waist size here is greater than 35 in male, and then greater than 31 for females. And like we said, we have high cholesterol, diabetes, and hypertension. So here are your modifiable and non-modifiable risk factors for CAD, in addition to metabolic syndrome. So which race, which ethnicity has the highest? Followed by Hispanics. Here are modifiable risk factors. No, stop smoking, lose weight, control diabetes, control hypertension, increase activity. So we already described how the plaque deposits. So again, long decades of eating, high fat diet, for instance, high sugar. So that will increase the plaque deposits in one or more arteries, and that takes time, correct? So prevention, of course, which ones can you control? Age, ethnicity? You change from black, become white? Okay, so we can only do the modifiable risk factors. So those conditions listed in, what was that chart? Chart 23-1. Okay. So I won't read the paragraphs. They're all, you should know already. Like, what do you do with the abdominal obesity? So how do you lose weight? Okay, eat better, become more active. Okay. What do you do with the cigarette? Can I just smoke weed instead of tobacco? Okay, it doesn't really say tobacco versus marijuana, right? So smoking is smoking. All right, so these are how you control them. Let's go straight to the treatment. So once you're diagnosed with metabolic syndrome, so now you have chronic stable angina, now we give you medication. So in addition to the activity, the diet, that's all good. Then we have to control it. So how did we get the high cholesterol? Is it only from diet though?
Not
because the body is producing 80% or 70%.
So therefore, what's the other factor?
It's the
Genetics, right? Yeah, genetics. So some people, like myself, for instance, no matter what I eat, even if I eat like a rabbit, my cholesterol remains naturally high because it runs in my family. Okay, so my father had multiple strokes. My mother was diabetic, hypertensive. So it's in my family. So it's not just diet. So I have to take, which is okay, statins now. Okay. So yes, lipid lowering agents like statins, they're harmful, right? They can cause what to your liver? It can damage your liver, right? They're harmful to the liver. However, there's really no other drug that has the best cardioprotection. So if you compare, because there are non-statin options, like this one, for instance, fibric acids, these are not statins. Like fenofibrate, that's not a statin. We have bile acid sequestrants. Example there is cholestyramine, okay, or cholestyramine. So that eliminates cholesterol to your GI tract, meaning it promotes, it's like a laxative. Okay, so that's a non-statin option. But again, data shows that among these, nothing beats statins. Okay, so statins still prove to be the most effective with providing cardio protection. Yes.
Would omega-3s be more of like a preventative prior to medication or without?
Well, you can use it in addition to. Okay, but omega-3, is that really FDA? No, right? I mean, it's doctors recommend that, but the FDA doesn't really, right? Yeah. So those are, there are data that support omega-3, but will you bet your life on omega-3 if you already have heart disease? It depends. Okay, so again, it's a free country. But just emphasize to the patients that these medications will be useless without the non-pharmacologic therapy like nutrition, exercise, quitting smoking, eating better. So here, stop smoking. There are many ways to do it. Just give the patient options. And most of our patients, because they are, how long did they develop the coronary artery disease? Does it go overnight? So this is a lifetime of habit, right? Of smoking, eating chicharron. No, this is a lifestyle now. This is how they are. So is it easy to stop smoking? So when they say, let's say Ms. Peguero comes in, hey, sir, I'd like to talk to you about smoking cessation. Okay, and then the patient will say, okay, thank you very much, young lady, but no, I like to smoke. Okay, will you just quit altogether? No, it may not be effective during this admission, but what about next admission? All right, they may have a different outlook. Okay, so each time, each opportunity offer, hey, it's never too late to stop smoking. We have alternatives. Here, you want a patch? Yeah, we have the gum. All right. So, always encourage them to stop smoking, because you never know, that last admission, something happened. Maybe the other episodes didn't really threaten them. No, they didn't have that much chest pain. Okay, but once, let's say they had a cardiac arrest, and we had to do chest compressions, and then they came back. Maybe that will change things, right? You never know. Here are your list of medications, and as with any other drug chart, what is testable? Nursing implications, nursing considerations. So here are your statins. So what do you teach the patient, and what do you educate them on? Okay, so statins are famous for muscle pains. So they always complain of body aches. Okay, myalgia, arthralgia. This is common in statin medications. These are annoying but harmless side effects. Okay. However, if the aches and pains continue to bother and now interrupts or interferes with a patient's job or ability to function in society, then they need to talk to their doctor, maybe explore non-statin options. So to this day, I still have these, but not bad. I mean, I can go to work, I get the pains in the morning, but they go away throughout the day. And monitor liver function tests. Should they be taking alcohol while on these medications? Okay, but of course they'll drink no matter what, but of course, educate them anyway. And when is it given? At bedtime, okay, evening or bedtime. And these are the non-statins, fenofibrate. They should not be taking double though, because evidence shows, because these drugs also, look at it, it also causes liver liver damage. So therefore, can you take a statin and a gemfibrozil? No, so only either or, okay? Here's the common generics. So we have, I mentioned cholestyramine. These again, these are powders, okay? So you take them with water or whatever beverage, take them at night also. But again, the problem is it will cause, well, yeah, it can cause GI bleeding, but it may cause constipation. Ezetimibe, sometimes we combine them. Ezetimibe together with another drug. I think it's this one. So they'll combine this one with this one. It's okay, right? So I forgot the name of the drug. It's 2 in 1. It contains this one and this one in one pill. What? No, robuvastatin is Crestor, right? No, you mean rosuvastatin. Okay. No, that's Crestor. This one, there's a, although I haven't seen it lately. Okay, so these are your statin medications. And of course, what were the other risk factors? Hypertension, correct? Okay, so they have to take their hypertension medications, which you finished last semester, right? These were the same medications you use for heart failure. What about for diabetes? Okay, so whether they're on insulin or oral hypoglycemics, same thing. And of course, lose weight. So these are all for chronic stable angina, right? So here are the options for quitting smoking, managing hypertension, diabetes. Okay. Educate women. Okay, look at this statement here. Cardiovascular events in women occur an average of 10 years later than men. So what does this statement mean?
The woman's catch it later.
What's the risk factor for women? What is it if you compare it to men? Women is higher risk for cardiac disease. In fact, statistics-wise, heart disease is the #1 killer for women. Okay, not really men. Men, I mean, pain-wise, who can tolerate pain better? Right? Because I mean, males don't, go into labor or or give birth. No, so women, especially moms, right? If you're a mom, do you have time to, think about your symptoms? Because you're so busy, you have 12 children. So you're the last, right? So you think about yourself last. Okay, you feel something, I'll do that later, right? Plus the problem here is the symptoms for women are not the same as those in men. So women have a more vague symptoms, atypical chest pain symptoms compared to men. Men have the classic chest pain, okay, the radiation to the jaw, to the arm. So it's easy to diagnose it in men, not so in women. So some women may just complain of it'll resemble GI symptoms. Okay, so then the women will take, antacids, for instance, Tums, like that, and then just disregard the symptoms. So that's why they have a higher mortality, right? So women, especially mothers, make sure, you get your yearly physical exams. Okay, so get checked out, especially for heart health. All right. No matter your lifestyle, even if you don't smoke, you don't you don't drink, for instance. Okay, so because there are again other ways, stress, right? The stress of womanhood can still increase your sugar, correct? So cortisol levels remain high, then that can put you at risk for atherosclerosis as well. So here's the chronic stable angina. As I described earlier, this is chest pain which has a precipitating event. These are the precipitating events. So whenever there is increased myocardial oxygen demand, which results from increased heart rate resulting from physical exertion or emotional stress. Besides the physical and emotional stress, these are other triggers. So we know about physical exertion. Exposure to cold, right, can also trigger the event. So that's why what happens to hospital at ER admissions for men over 50 during winter? Because what happens during winter? Except the last few years because we didn't have much snow, right? But men over 50, when they shovel snow, it actually sends them to the ER because of angina, right? So undiagnosed coronary artery disease, that's usually the trigger. Okay, that what were you doing? I was shoveling snow, right? And some of them don't make it because they can go straight from stable angina to a heart attack. Okay. Okay, I won't test chart 23-2 because really angina is angina, right? Doesn't really matter whether it's Prince metal. We'll get to the differences when we get to acute coronary syndromes. Okay, so in angina pectoris, also known as chronic stable angina, these are the description of the chest pain. So it can be described as, mild indigestion, right here. Could be like a heartburn, choking sensation, heavy sensation. So these are the different descriptions. It may be accompanied by these associated symptoms, meaning it radiates to the neck, jaw, usually on the left side, because it follows the nerve pathway to the cardiac. It's always on the left side. So here they feel like there's tightness or choking sensation. Who's felt like this lately? Anybody? So if you've had this, okay, have yourself checked out. Okay, is nursing also a stressor? Nursing school? Yeah, it's equivalent to eating drive-through for 5 semesters. So here are more symptoms associated with angina pectoris. We'll discuss unstable angina later. But since the description is here, let's just talk about it. Unstable angina can result if, let's say, you have angina pectoris, but obviously, did you listen to the advice of the physician? Did you comply with the treatment? No. So did your atherosclerotic plaque remain stable? No, it didn't remain stable anymore. So if it gets worse, so let's say you continue to smoke, you continue to eat high salt foods, high fat foods. So does it remain the same size, the atherosclerosis? No. When it gets worse, then it goes from chronic stable angina or angina pectoris to now unstable angina. Unstable angina is now one of the 3 acute coronary syndromes. Okay. So the characteristic, if the typical chest pain you had before, how did the chest pain come about again? Were they just laying down like this, watching TV? No, something happened, right? It was precipitated by an event that increased the heart rate, correct? It led to an increased oxygen demand by the heart muscles. Here in unstable angina, so if the patient with angina pectoris now experiences chest pain at rest, and usually when they have this diagnosis, the doctor prescribes nitroglycerin. either spray or sublingual. And they take it either preemptively or in response to chest pain. So let's say I have angina pectoris, I'm given nitroglycerin. Nitroglycerin always comes in a brown glass container, so don't take it out. That's one of the teachings you tell them, because some may say, oh, I'll just bring a few in a Ziploc bag. No, it's in a brown glass container for a reason, because why did we put something in a brown glass container? It's light sensitive, okay? And does it stay there for, does it stay viable or no effective if it's placed in a plastic Ziploc bag? No, it starts to deteriorate. So teach them to keep it in the original brown glass container. So let's say they have angina pectoris and then they were taught, okay, either preemptively do it. Let's say you have to shovel snow, you have no one else, okay, to do it. So you take a nitroglycerin tablet before you start shoveling. That way you have vasodilation, you don't have the chest pain. Okay, you can finish the shoveling. Or before sex also. Let's say, oh, last time I had sex, my wife was angry because I couldn't finish because I had chest pain. So they can take, yeah, one tablet and then they can finish. Okay, everybody's happy. However, if this patient has the chest pain and then it didn't respond, right here, it did not respond after they stopped the activity or after they put nitroglycerin, is it angina pectoris? Not according to this paragraph, right? So therefore, if the patient takes nitroglycerin and then the chest pain does not respond to rest or nitroglycerin, is it angina pectoris? It says here, unstable angina is not relieved by rest or administration of nitroglycerin. So I repeat, they have chest pain, they took nitroglycerin and took a rest, the chest pain did not go away. Is it angina pectoris? No, it's now unstable angina. You still need me to repeat? All right, just are we clear? Is unstable angina one of the acute coronary syndromes? Yes. So remember, angina pectoris, this is a chronic stable plaque. They have atherosclerosis, they have coronary artery disease. However, is it getting worse? No, it's either staying the same or getting better, okay, because they're complying with treatment. So unstable angina happens when they either, yeah, not comply with the treatment or not change their lifestyle. Are we clear? All right, let's go to the diagnosis now. So let's say you have chest pain. We put, well, the moment you get to the ER, or even if, let's say if you call 911, so they'll do an EKG on the ambulance. The changes will be the following. If during the chest pain episode, there will be T-wave changes. There will be some T-wave inversion, ST elevation, and abnormal Q-wave. These, however, are present in acute coronary syndromes, okay? So if you're just having ischemia, there may be some T-wave at some of these, right, these changes. However, they do not stay. They come and go. So while you're having the chest pain, they appear. However, when the chest pain, let's say we took nitroglycerin, the changes return to baseline. You follow? Okay. So when you get to the hospital with acute coronary syndrome manifestations, okay, so unstable angina, and STEMI, for instance, the first thing we need again is a ECG. It has to be a 12-lead ECG to make a diagnosis. So we do that in less than 10 minutes upon arrival, so that we can proceed with what's next. Okay, what do we do next? Well, it depends on the diagnosis, right? If the patient responds to nitroglycerin, then what is it? Angina pectoris or chronic stable angina. Doesn't respond.
Unstable type.
We don't know. It could be unstable angina, or remember, that's why do we call these three? Unstable angina, non-ST elevation MI or ST elevation MI. Why do we call them all acute coronary syndromes? The answer is we cannot tell the symptoms apart. Let's say we put three. So let's say it's Faith, Shanice, and the other Shanice. They come in, let's say Faith has unstable angina, Shanice M has NSTEMI, and then Shanice S has ST elevation MI. Different diagnosis, right? But their symptoms will be exactly the same. So you put them side by side, 3 cubicles in the ER, their manifestations are exactly the same. The only way you can tell them apart is with an ECG. They will have different ECG readings. Plus, when we draw blood, which ones will have a positive troponin? She will have a positive troponin. Shanice M and Faith will not have a positive troponin. Okay, because yeah, it's not, there's no, I mean, well, she will have positive, sorry, she will have some elevation of troponin, but not really high. Okay, because yes, she had a heart attack. However, the difference between NSTEMI and STEMI is really how deep is the MI. So let's say this is the myocardium, right? This is the right ventricle, left ventricle. So in NSTEMI, this is an MI. However, the thickness of the MI, the infarction, is subendocardial. This part of the myocardium died. So if this part died, is this part still alive? This died. So what about the rest of them? They're alive. So will this part still contract?
No.
They're alive.
Yes.
So will they contract?
Yeah.
Yes, the heart will still contract. However, is it weakened?
Okay.
Yes, it's weakened. However, the death is only subendocardial. That's NSTEMI.
That's what I had. Yes.
Really?
Okay.
So in the ECG, this will be manifested by ST depression, not ST elevation. It'll be like this. Okay, so this is what we call ST depression. Okay, this will be what NSTEMI will look like. Now let's go to STEMI. STEMI is a full-blown heart attack. The whole thickness died. So since this whole muscle died, will it contract? No. So on the ECG, this is what we call now ST elevation, with or without T-wave inversion. So you have two problems here now. This ST elevation, T-wave inversion, and sometimes also the Q will also be abnormal. Sorry. The Q will be abnormal as well. We call this a pathologic Q. So it could be one or more of these. So you'll have a pathologic Q or abnormal Q wave, ST elevation, and T wave inversion. So this is for STEMI. Okay, so this is evidence that a large thickness of the myocardium died. So this is an emergency. This patient has to go to the cath lab. This one, yes, it was an emergency when it occurred. However, it stopped. All right, meaning it did its damage already. Meaning, yes, it died, it killed off this one, but there's no evidence that it's still doing it. All right, so therefore, this part is already dead. Can you bring it back to life? So what we can do is just, yeah, we'll treat it, but we'll wait. Okay, we have like 2 to 6 hours or even overnight to fix it. Okay, because why did this patient have a heart attack? Because they have atherosclerosis. So do we need to open those coronary arteries? Yes, so that they don't get another one. Okay, this one, however, we have to fix it now because is this gonna stop? No, this will extend. This will extend further because is the blockage of the artery cleared? No, it's still there. So we need to save what we can. The patient has to be sent to the cath lab to save what's left of the muscles. You understand? Okay, this one, yes, something died. A part of the muscle died, but not anymore. Okay, the changes because we only see this. We don't see the ST elevation anymore. So this one is ST depression. So that's evidence, yes, you had a heart attack. But no, we can prevent new ones. Okay, so we'll do the intervention tomorrow. Okay, we'll send you to the cath lab. We'll fix your arteries. So this is the gold standard. PCI stands for percutaneous transluminal coronary angioplasty or percutaneous coronary intervention for PCI. They may or may not use stents. The cardiologist will decide, do we put a stent in or not? Medications during the acute episode, of course, is nitroglycerin. However, the sublingual nitroglycerin, is it long-acting? No, they only last for 3 to 5 minutes. So therefore, we keep giving you nitroglycerin forever? No, we only give you up to 3 doses. But let me give you a scenario. So let's say you have angina pectoris. You've been taking nitroglycerin. Okay, so let's say before activity, you've been taking it for a while. But then this one chest pain episode, so you're used to it. So you have chest pain, you take one tablet, it improved. Okay, but then the pain is still there, but it improved. Okay, let's say it was level 8 earlier, you took a nitroglycerin, now it's a 6. 6 got better. So you take a second one. Now it's a 4. Take a third one. Okay, 0. You take, let's say this chest pain episode, it's there. Take nitroglycerin. 5 minutes later, it got worse. What do you do? Why?
It's getting worse and it's not working.
Exactly. Is it angina? It's not. It's one of the 3. Yeah, we don't know. It could be unstable angina. I hope it's unstable angina. But what if it's NSTEMI or a STEMI? So if you take nitroglycerin, it's supposed to improve, right? But it didn't. It got worse. So what do you do? All 911. While waiting, what do? You can take the second and the third. Okay, hopefully 15 minutes, the ambulance is there already, right? Because it's a chest pain.
Stop, like you stop talking to the phone.
There's really no, I mean, it's not really evidence-based. So after, let's say, after your diagnosis, nitroglycerin comes in different forms. So the nitroglycerin sublingual is only for short term, okay? And then for, emergencies, let's say you have a severe physical or emotional event, so that will help. However, if the patient has a known or let's say they suffered a heart attack, we no longer just give them short-acting nitroglycerin. We're not going to give them long-acting. So instead of the sublingual spray, we're now giving them capsules now. Give them oral capsule or ointment. When it's an ointment though, please remember to remove it in 12 hours. Ointments. So nitroglycerin ointment should only be on for 12 hours because you develop tolerance to it. Okay, so over time, the more you put, if it's topical, okay, ointment. If it's an ointment, they should be on only for 12 hours because you have to take it off. That way you don't develop tolerance because otherwise the ointment won't work anymore, right? So you may say, oh, what do I do now? I need the nitro. Well, you take a different form, right? But if it's ointment, it should only be on for 12 hours. And we can also give it IV. So obviously if it's a patient having a heart attack, and then because it will take a few minutes before we can take the patient to the cath lab, because does it make sense that you take them to the cath lab, but then nobody's there? Doesn't make sense, right? So that scenario can happen if, let's say, it's after business hours. Okay, so because the cath lab people won't stay there. It's not worth the money if you pay someone to do nothing. So what they'll do instead is put people on call. Let's say Ms. Kalu works in a cath lab, right? Then they'll ask you, okay, who wants to be on call tonight? Okay, yeah, I'm on call. No, all right. So they'll call you if they need you to come. All right, but when they call, you better be ready. Meaning you can't take, okay, I'll come in an hour. No, that means because they're paying you an on-call rate. No, whether you're called or not. So you're getting paid for staying home, but you have to be ready. Meaning you're dressed. You're ready to leave when they call. Hey, it's not like you can, oh, I'll take a shower and then leave. No, you leave right now, right? Because we have a patient. So you have to be in the facility in less than an hour because the time limit for emergency cath lab is 90 minutes. Meaning that 90 minutes means when they enter the ER, within 90 minutes, the coronary artery is already open. Does that make sense? Meaning the balloon is already in and they blew it up. Because remember, we have to do preparation, right? We have to prepare the patient. No, there'll be doctors in doing tests, making sure this is a safe procedure, right? Then they'll find the proper artery, left or right radial, or if they can't do those, then we'll go femoral, right? So here's another drug chart. So on top of nitrates, why are we giving beta blockers when the patient's having a heart attack? Okay, because whenever you have a heart attack, what happens to cardiac output? Your heart is injured. So what happens to cardiac output? It will automatically, therefore trigger what? Sympathetic hormone. So once epinephrine is released, what happens to that heart rate? It will increase even more. So therefore, does it help the scenario? No, because this heart cannot pump effectively. So you have to suppress the sympathetic hormone. So give them beta blockers, large amounts, 50, 100 milligrams. So we keep the heart rate low. And then calcium channel blockers will be given, IV as well. So this will control your dysrhythmias. Yeah, the heart rate also plus the dysrhythmias will be managed as well. Then we'll get antiplatelets. First one given is aspirin. Hopefully this was given already by the ambulance. Then when you get there, you can be given clopidogrel. So these are both antiplatelets, but they work slightly differently. Plus in a heart attack, we really don't give one antiplatelet. We give them dual antiplatelet therapy. So aspirin and clopidogrel. Anticoagulants only during the hospitalization. Don't worry, because even if you say, oh, but the patient's going for invasive procedure, shouldn't we stop this? Remember, what triggered the heart attack? What caused it? A blood clot, right? So do we want blood clots to form?
No.
Is the patient immune from a second heart attack? Because they're already having one. Can they say, oh, I'm having a heart attack now? There's no way I'm getting another one.
No.
Yes, they can have multiple. Okay. So we give them heparin. Don't worry, we will stop the infusion 1 hour before we start the procedure. So until then, start heparin. Okay, we don't want new clots forming. Okay, we already have a clot causing a heart attack. We don't want any more. As far as which one, of course the doctor will decide whether it's IV heparin or one of these low molecular weight heparins, either enoxaparin, which is Lovenox, or dalteparin, which is Fragmin. Okay. What type of shock could result here? Cardiogenic shock. So watch for cardiogenic shock symptoms, which is usually just based on the MAP. If the blood pressure drops below 90, then do we suspect cardiogenic shock? Yes, and then after that we will give the IV dopamine, etc. With nitroglycerin, I forgot to mention this earlier. This will cause a headache, as will any other vasodilator. So you can give Tylenol together with the nitroglycerin. By the way, how do we give sublingual medications?
Under the tongue.
Okay, and what if the tongue is dry? With what? Spit?
Where's it going? Wait, keep going. What's the statement? Yeah, a little bit of water to it.
Okay, so how much water, Kurt?
Small amount.
How much? It's like small vodka for me is like a pint. What is small? How much?
5 ml.
Very good. 5 ml, 1 teaspoon. Just to, do I use it to swallow the tablet? Just to moisten your mouth. Because otherwise, if it remains dry, will the tablet dissolve? No. Is dry mouth common?
Yes.
Yes, when you have vasoconstriction, sympathetic nervous system, your mouth dries up, right? Okay, so beta blockers, we already explained why. Oxygen should have been given. We haven't seen oxygen yet, but oxygen should have been administered upon admission or from the ambulance. All right, so here's teaching, because this patient, once they're discharged, assuming they survive, right? So we send them home. What should we teach them about nitroglycerin? Again, patient's mouth must be moist, because otherwise that tablet will not dissolve. 5 minutes later, it's still there. It's still there, still whole, dry. And take note, they do not swallow it. If needed, they can crush it. Although it comes in a spray now, so a spray would be better than the tablet. So they carry it everywhere. Again, I repeat, keep it in its brown glass container. Don't take it out, so otherwise it won't work anymore. So it's inactivated by heat, light, moisture, and they replace it every. Okay, what do your grandparents or your parents do with medications? Right? Yeah, because what's wrong? Especially, let's say, insulin. Okay, because we tell them to discard it after 28 days, right? But the vial is still full. What do you mean? Throw it away, right? So explain to them that doesn't work anymore. It's useless. So I described this already. You can preemptively take it. Let's say you had chest pain before sex, for instance, or before jogging or before shoveling snow, then take it ahead. So here are examples of activities. And okay, so it's expected to work within 5 minutes. Again, what do we tell them if it doesn't improve? Okay. These are side effects. So I already explained that because vasodilation, although the target is really the coronary arteries, can it have systemic effects? Yes, so you can have headache, hypotension, and tachycardia as a result. What causes the tachycardia? The hypotension triggers tachycardia. Okay. Of course, this should be the first one you do, right? Yeah. I mean, do they continue with the activity with chest pain? Say in the middle of sex, let's finish. Okay, and then, okay, you have to stop. I like that. Okay, so antiplatelets we discussed. Clopidogrel, heparin, all right. Any heparin is heparin, whether it's unfractionated heparin or low molecular weight heparin. You still remember HIT? So what's the manifestation again? How do you know the patient's having HIT? Okay, besides the bleeding, what will you notice on the labs? Okay, bleeding time no, actually no. Bleeding time does not increase. Bleeding time shortens, right? Because these patients are clotting, remember? So what will happen to the labs? What will happen to the platelet count? It'll drop by how much? Half, okay? What happens to the PTINR? Decreases. What happens to fibrinogen levels? High. What happens to D-dimer levels? High. Very good, children. Oxygen should have been earlier, okay? They put it here in the bottom. It should have been the first thing you gave.
So that's the first intervention.
Right. If you read some articles that say, don't give oxygen to non-hypoxemic patients having a heart attack, it's still an article, okay? I mean, the textbooks doesn't really say that yet, but until then, until the textbook says otherwise, we continue oxygen. Are we clear? Okay. Or follow agency policy, because some agencies have policies in place already. So just follow that. But for the NCLEX, do we give oxygen? Keep in mind your pain assessment, it should be complete. Okay, don't just say, okay, where's your pain and then how bad is it? Complete it with the characteristics, okay? And the mitigating and the aggravating factors as well. Morphine. Where is morphine? Okay, morphine's not on this page. Oh, that's preventing. Okay. Oh, positioning. If the position will depend on the blood pressure, because let's say this patient is in cardiogenic shock, what position of the head will you place the patient in? The patient is in cardiogenic shock, meaning blood pressure, systolic blood pressure is below 90. Okay, so do not raise the head of the bed, right? Because even though, is this patient short of breath? Yes, that's the number one symptom. Okay, in addition to the chest pain, the patient is short of breath, correct? Because oxygen levels are low. Now, instinctively, what would you do? Raise the head of the bed, right? But if the blood pressure is less than 90, what do? Put them on modified Trendelenburg. Are we clear? You can put one pillow. The modified Trendelenburg doesn't really mean flat. You can put a pillow which will put the head at what? 10 degrees, right? 10, 15 degrees. Okay. That's okay, but never put them Fowlers or semi-Fowlers. What is the expected sensation when the nitroglycerin is given sublingually? What will the patient feel?
Relief?
Burning sensation. Burning, no, under the tongue. So there's supposed to be burning or tingling sensation. Is that good or bad? That is expected. If you don't have any tingling or burning sensation, the drug is not working. Okay, so it's probably old or damaged by sunlight or moisture. We do give morphine, but you know what? I bet it's on the next page. Okay, it's right here. So morphine is on this page. So collectively, those three I mentioned, unstable angina, and STEMI, are called acute coronary syndromes. Why again? You can't tell them apart. So all three are there. They have the same symptoms. Chest pain, how do we tell them apart again? ECG. So what's the first thing we do upon arrival? ECG. 12 lead, okay? So I already explained earlier the difference between NSTEMI and STEMI. So the 12-lead ECG allows the physician to make a quick diagnosis as to the type and location of the MI just from the ECG changes. When we look at the Q wave, ST and T wave changes, you can make a diagnosis based on that. Manifestations, we've been repeating this. So in addition to chest pain, keep in mind the associated signs and symptoms. What's responsible for those associated signs and symptoms there, by the way? The shortness of breath, indigestion, nausea, anxiety, cold, pale skin, and decreased urine output, which is not mentioned here. What's responsible for those? Sympathetic nervous system. Okay, so if you relate this to shock, similar symptoms, right? So this is triggered by the sympathetic hormones. It's what's causing the associated manifestations in addition to the chest pain. So we need a 12-lead ECG within 10 minutes, then draw blood for your cardiac enzymes. Okay, so for your troponins, T and I.
They don't have a 12 lead inside of ambulance?
They do. That's why I said, this will be done already in the ambulance. However, they still do another one on arrival to the ER. So in an MI, again, I already described to you T wave inversion, ST elevation, and an abnormal Q. So we have, where's 23 dash, right here. So here's the inverted T wave. Here's the ST elevation, and this is the pathological or abnormal Q. So these are the three acute coronary syndromes. How can we tell them apart again? And what? Cardiac enzymes. Okay, so you send for troponin. If it's a NSTEMI, remember we have time, right? So if that's a STEMI, they go straight to the cath lab. The echo can be done for an NSTEMI because we're not in a hurry, remember? So we can do the echo. So we'll draw troponin. Between C, I, and T, we draw troponins T and I, okay, because they're more specific to cardiac muscle. Keep in mind that, let me show you the time, time. Okay, so let's look at this one. The vertical axis is the amount, the levels of your cardiac enzyme. The horizontal axis is days. This is not hours, okay? This is days. So the heart attack occurred here, right here. Which one rose first? Because we have 3 cardiac markers here. We have CKMB, we have myoglobin, and then we have troponins T, troponins I. Which one rose first? Myoglobin. However, how long did it stay? Within 24 hours, it's gone, right? Right here. It already dropped. Within 24 hours, it's gone. So is it reliable? CKMB, same thing. It rose fast. However, does it stay? Again, it's gone by 2 days. It's gone. It's only troponins that remain until almost 2 weeks. All right. So why do we want to see a peak though? What's the meaning of a peak or the significance of a peak? Let's say during Governor Cuomo's, during COVID, what was he talking about every 6 p.m. conference, his news conference? He was trying to show us the numbers, right? So he was talking about no peak yet. Okay, the numbers continue to rise. And then finally, when we saw a peak, so why are we happy when we see a peak? How do you see a peak? You can only see a peak if the levels start dropping, right? So therefore, so if you were still here, is this a peak? No, peak is not in sight. We only identify a peak if the numbers start going down. So do we want to see a peak? Yes, the sooner we see a peak, then the better the outcome. All right. So which is, again, this is days, right? So when do you want to see a peak? In 24 hours, 36, or 12?
Well,
I like 12 better, right? So if it peaks in 12, that means, did we do a good job? Yes, we started dropping the troponin, because what released troponin again? The dead or injured cardiac cells. So those cells, when they either got injured or died, they released troponin. So therefore, once they peak sooner, then that means, did they still die? No more. They stopped dying. Okay. However, the dead ones continued to remain in the blood, right? So don't expect troponin to drop after a few days. It will remain elevated until up to 10 days, okay? Sometimes up to 2 weeks. But as soon as the numbers steadily goes down though, are we happy? Yes, that's what once we see a peak, and then, we see the sooner again it peaks, 12, 18, or 24 hours, the sooner the better, right? So, however, don't expect it to drop. So let's say when you take an exam question, let's say, remember, it's next gen, right? So I'll give you data on what were the troponins on what day, on what time, okay? Because we order troponins every 6 hours, every 4 to 6 hours. So we trend it. So you look at your lab results. What are the numbers and what do they look like over days? So it may not be a graph. It may just be a column with numbers, right? And then you graph it yourself. What's the number? What are the numbers trending? Are they going this way or they're going this way? All right. So if you, depending on that, and then you, of course, is this reportable? If it's going down, do you report it?
Was expected.
When we say report, you want, it's something,
No, no, it's not.
no, it's not really, when in an exam question, when we say report, is that really like a good news? Like, hey, doctor, you won the lottery. Is that really what you call? No, we call because something's wrong, right? Something is critical, right? So therefore, if the numbers start going like this, do you report it? No, because this is good, right? Yeah, that's good. However, let's say the numbers start going down right here, but then on the third day, it started rising again. Is that reportable? Yes, because what's happening there? If let's say you started seeing it go down, but then it started rising, how do you explain that?
Is more tissue down.
Yeah.
Which means what happened to the patient? They had another heart attack. Very good, right? Because can they have another heart attack? Yes, you can have multiple heart attacks in a single admission. So again, which among these three? So troponin, CKMB, and myoglobin, which one do we? Troponins, T and I. So here's the summary for our treatment. Chest pain, patient had no relief from the nitro, call 911. Within 10 minutes, what do we do? ECG, 12-lead ECG, and grab your blood work. And depending on the ECG, if it's pathologic Q, ST elevation, T wave inversion, that's a STEMI, correct? So they go straight to cath lab. If it's ST depression, that means it's NSTEMI, correct? So we don't really necessarily have to hurry. So we can do the other diagnostics, okay, in that scenario. And then these are your drugs. So hopefully somebody gave the patient oxygen already, beginning at the ambulance. Nitro, morphine, aspirin, beta blocker. I know you've heard of MONA, right? Like nurse, if you work in a hospital, have you heard of the acronym MONA? Okay, so it can be MONA is simply to help us remember better. Because Mona is easy to remember, right? It's a girl's name. However, the actual order is either ONAM or ONMA. So oxygen first, followed by nitro, and then aspirin or morphine. Okay, so it's either ONAM or ONMA. All right. Most facilities though go ONAM because which one's easier to give, aspirin or morphine?
That's
Yeah. Plus, are they really? I mean, are they the same route? No, aspirin is easier to give, right? Because it's by mouth. So you give that because you have to draw morphine, correct? So someone's drawing morphine, someone's already giving the aspirin. So it's usually ONAM. But you can go ONMA. But again, it's easier to give it's faster to give the oral. Okay, what happens if the patient gets to a facility with no cath lab? Meaning, is this an option? Like my hospital, we don't have a cath lab. What if the patient having a heart attack gets to my hospital? What are we going to do? We don't have a cath lab. This is the, this is the option. Because if you transfer them, let's say it's a STEMI, is that an option to transfer them? No, they'll die during transport. They're not stable. So this is the only other option. This is just as effective as PCI. However, between the two, this one has the least complications though. So let's say the patient did not do their homework, right? They don't know, wherever they live, they're not familiar with hospital. They had no preparation. Like, where do I go if, I'm having a heart attack? This place has no cath lab. So where do I go? you go here. Okay, so let's say you go to Presbyterian, they have a cath lab. If you go to the other hospital because you didn't know, or let's say you panicked, the only thing they can offer you is thrombolytic therapy. So you'll be given alteplase or tenecteplase. What are those drugs? So alteplase is a clot buster. So here, so these are your options. They'll give you alteplase, tenecteplase, or retaplase. These are thrombolytics. Number one complication is hemorrhage, bleeding. But you're given this option, okay? So the only thing we can give you is thrombolytics. Then the patient or the family, no, we don't want that. It's not really a choice, okay? You'll die in transport if you leave the hospital. Can they leave the hospital? Of course, it's a free country, right? Can't force them. They're alert and oriented. However, do you really advise them to go if it's a STEMI? No, this is what we're going to give you, right? Of course, we need consent because can this kill? Yeah, patient could bleed to that. So we need consent before we give this drug. So that's the option, okay? Okay, we know the ONAM, okay? So good. If again, the facility has a cath lab, that's our first choice, right? So we'll call everybody if it's after business hours. So if you want to have a heart attack, do it during business hours, okay? Don't have a heart attack at night or after midnight, okay? It's not a good time. You have a chest pain, can it wait? Wait till the morning to get to work. Some of us need some sleep here, right? So here's thrombolytics. We'll talk more about thrombolytics under stroke. Because really in heart attacks, is this our first choice? No. Plus, how many hospitals do we have in New York? Okay, almost everybody has a cath lab. Okay, so again, our first choice is cath lab, PCI. You don't like thrombolytics, too high risk for bleeding. So once the patient is stable, then we treat because we prepare for a future heart attack, right? So how do we decrease the likelihood of a future heart attack again? So what drugs will basically the patient be on? Aspirin every day. What's the partner for aspirin? Clopidogrel. Okay, those two. What else? No. Heparin Lovenox is only during inpatient. Okay. So when we discharge these patients, they had a heart attack. Remember, they had the PAT, right? The atherosclerosis. So what do we do? Statins and ACE inhibitors. And what's the other one before ACE inhibitors? Beta blockers, right? What else? Calcium channel blockers, yeah, or ARBs if they can't tolerate the coughing or they develop the coughing from the ACE inhibitor. Okay, and then nitro, right, for as needed. Okay, so those are your standard medications. And stop smoking, okay? Tell them, for God's sake, stop smoking, okay? You already had a heart attack. You got lucky this time, you're alive. You may not survive the next one. Just briefly for thrombolytic therapy. So here's your choice again. No cath lab, right? So this is the only thing we can do for the patient. However, if the patient does not meet these, meaning the chest pain's been going on for over 12 hours, can they really benefit from the thrombolytic? No. The benefits, I mean, the risks outweigh the benefits, so no. Okay, so these are the indications. Absolute contraindications. You cannot have thrombolytics if you have any of these. Active bleeding. Menstruation is okay, right? Menstruation is not really an absolute contraindication. known bleeding disorders such as hemophilia, okay, or any clotting factor deficiency, or ITP, like that. History of a hemorrhagic stroke, or if you have doesn't have to be, this vessel malformation is referring to AVM. Have you heard of an AVM? What about an aneurysm? Yeah, you know aneurysms. Okay, so AVMs is another type of vessel abnormality wherein a vein and an artery is connected. Are veins and arteries normally connected?
No.
No, it's supposed to be separate, right? And then how do they meet? At the capillary. So this one, an AVM, is called an arteriovenous malformation, meaning congenitally, you were born with it. You had an artery and a vein abnormally connected. So what will happen to that as you grow? They get bigger and bigger. And then, so if you have that, then no thrombolytic for you. You had a recent trauma or surgery. Recent meaning in the last 3 months. Or you have uncontrolled hypertension, or you're pregnant. They can't give you alteplase. Whenever you give these, of course, the number one concern is bleeding, correct? So make sure you don't unnecessarily poke this patient. Watch for signs of bleeding because, yes, it's inevitable. There will be some bleedings. Do we check temperature rectally? Okay, avoid that. Can we give them enemas? No. So avoid any invasive lines or tubes as much as possible. And then, of course, monitor for, do we check for late or early signs of bleeding? Early. So here are your early signs. And once you identify the early signs, then you treat them. Cardiac rehab is not really on your tests because this is a long period. Okay, usually we don't have much inpatient cardiac rehab here because it's usually outpatient. Because do patients really want to stay in a hospital for rehab? No, they prefer outside, right? Or let's say even outpatient. Okay, let me just finish this and then we'll go take a break. So let's do your responsibilities for the PCI now. This will be quick. So when the patient has a PCI, which is the cardiac catheterization, or let's say they have more serious problems, meaning they can't do a PCI, but rather they'll require bypass grafting, then it'll have to do that. PCI. So this is cardiac catheterization. This can be diagnostic or therapeutic. Please keep in mind that when they do a cath lab, cardiac catheterization, sorry, it involves a dye. Okay, it involves a IV contrast agent because otherwise, how can we see the coronary arteries if there's no dye? Can you? No. Okay, there's no camera. Okay, so it's not like you put an instrument there and then, is there a camera as small as a coronary artery? No. Okay, so we use IV contrast agents. Okay, so and then we'll take pictures and then we'll see, okay, which coronary artery is blocked, how many are blocked, where is the blockage. Okay, so they'll see that on the picture and then they'll do their thing. Okay, so put the catheter through and then they know where to inflate the catheter. Because it uses a dye, what is your number one responsibility? Okay, number one is allergy. What else? What drug should be held after exposure to this? Very good, metformin. So are diabetics the ones who get a heart attack? Yes. Okay. So if they're on metformin, make sure you tell them or hold it, okay, because they're not going home anytime. So they'll be inpatient. Make sure nurses are aware. We hold it for how long?
No, oh, 1 hour before that.
2 days, okay? 48 hours, you hold it. What about before? They already took it this morning.
Give them-
Nothing we can do about that, okay? They already took it. But moving forward, we should hold it, okay? Because do you plan a heart attack? Say you have your metformin now. Do I take this? Wait a minute. I'm supposed to have a heart attack tonight. No, I'll hold this. And you do that. Not exactly, right? Okay, let's go to the responsibilities. So all of these are just describing, okay, which is nice, okay? This is nice to know. This really doesn't tell you what you're supposed to do. So let's go to your, right here, post-procedure. So what do you do? Patient comes in, comes back to your floor after the PCI. So what are your responsibilities? This involves the insertion of a catheter through an artery. So when they take that catheter out, so what's your number one concern? The site, okay? So usually nowadays we do radial artery now, left or right radial artery. Femoral is very rare now, if not altogether avoided for obvious reasons, right? Meaning, why do we not want the femoral anymore? Plus, that means if we use a large artery like that, can the patient get out of bed after the, no, we're forced to put them on bed rest for 6 hours or sometimes 8 hours. What could go wrong if they're on bed rest? Exactly. So we really don't want the femoral, right? We want them to be up and about as soon as possible. If it's a radial, then there's no activity restriction. Patient feels fine, walk in the hallway, okay? Sit in the chair, okay? Be active. So this is what you'll see on the site. So they'll have an angio seal there. It's a very sticky dressing, okay? Very tight, sticky dressing. We use FemStop for femoral artery access because sometimes the patient develops what's called a pseudoaneurysm. A pseudoaneurysm is not really an aneurysm. It's a fancy name for a hematoma. Okay, so obviously this happens because the clot that formed at the site at the femoral got dislodged, and now the patient bled, and the hematoma is this big. Okay, so to stop that, we put a FemStop. Let me show you what a FemStop looks like. This is a FemStop. So this round half circle here, no, half, what is this? A half ball presses on the artery. Then you wrap this whole strap around the patient's hip. Okay, so you strap it around here. Okay, and then this ball is what you put, you position it over the artery. Then you pump this, it will tighten the strap and then put pressure on the femoral artery. How much pressure? Well, I forgot the exact number, but you always check the pedal pulse, because if you pump it too high and then the pedal pulse disappears, what's wrong? No blood flow. Okay, so you pumped it too much. Okay, so the pressure is too high. So release the pressure. Make sure there is still a pedal pulse. Okay. So these are emergency devices. Okay, so let's say your patient came in with a femoral access, then make sure you have a FemStop ready, because it can happen anytime. Although rare, but these are the possible complications, right? Table 23-3. Again, they are rare. So this is the pseudoaneurysm I described earlier, but usually this is for a femoral access. We don't get those in the radial. Let's go last one, then you go on a break. CABG. So this is indicated if the patient has one or more of the following. It was an unsuccessful PCI. We tried the cardiac catheterization. We couldn't open it. Or the patient has multi-vessel CAD. I mean, what are you going to do? The patient has 3 or more coronary arteries. Are you going to open each one at a time? Meaning what this means is, let's say, when we say 3 or more vessel disease, that means this is an artery, right? It means that this, and this, and this are all blocked. Do you follow? Meaning it's different branches of the same coronary artery. So does it make sense opening each one? No, you're better off bypassing the whole thing. All right? Because there is, I mean, that artery is no good. Okay, so you better bypass the whole thing. So that's what they do in CABG. You understand? Okay. So I'll show you a picture because there are 2 options here. They either use the mammary artery or the any of the leg veins. So this is an example of using a leg vein, okay, either the saphenous vein or peroneal vein, whichever vein looks good. Okay, so either this is a vein right here, obviously, right? So they can use that, or they can use an artery. Okay, so they'll pluck out the internal mammary artery, then use it as the graft. So obviously, which one is gonna last longer, an artery or a vein? This one will last longer. So which one they'll choose depends on a number of factors. How old is the patient? Okay. What are the patient's risk factors? So if the patient's likely to live longer, what do you think they'll use, an artery or a vein? They'll choose an artery. So this is open heart surgery. So expect a large sternal incision. And what will be coming out here? Because let's say you do, just imagine the surgery, okay? So how exactly did they put that there? Is the heart beating in this particular surgery? Is this patient's heart is beating? Can you stitch those vessels? No. You have to stop this heart from beating. So therefore, what will the procedure entail? We have a heart-lung machine. Okay, so there'll be large tubes that will bypass the heart altogether. So they'll bypass the patient's circulation to a machine, right? So there'll be large tubes. So the heart, the blood goes out of the patient and then returns to the patient, okay, via the heart-lung machine. So that machine will circulate and oxygenate the patient's blood, right, during the procedure, because the heart will stop beating, okay? So while they do their thing, so they stitch these, and then when they're ready, of course, you stop the heart. So is the SA node working? No, not if you stop the heart, right? So therefore, once they finish with the procedure, there will be pacemaker wires inside the patient. Okay, so there'll be 2 wires, one in the atrium, one in the ventricle, to pace it. Okay, so that when it starts working, so it'll stay for probably up to 24 hours. The patient's rhythm is okay, then they'll take the pacemaker wires out. And then, of course, because is there a lot of bleeding here? Remember today in lab, I mentioned you'll have a chest tube. Okay, so of course, these are smaller tubes. They'll put 2 mediastinal tubes. We need 2 because in case one gets clogged, what will happen? What could happen? There's bleeding here. So if the blood can't come out because this thing is blocked, What do you call that condition? Very good. Cardiac tamponade will result. Is that life-threatening? Patient will die. What do you call those symptoms again that indicate cardiac tamponade? Beck. Okay, Beck's triad, B-E-C-K. What are those three? You got that? Muffled heart sounds, jugular vein distension, and hypotension. Or if the choice includes pulsus paradoxus, that's also included. So saphenous is very commonly used, or again, the perineal can also be used. Vein harvesting is now done endoscopically. During my time in the, not that long ago, early 2000s. Okay, so early 2000s, we still had to harvest the vein the old-fashioned way, wherein we cut the entire leg. So we'll cut it from here to here. So a very long incision, and then we'll take out the vein. Now you'll just see 2 or 3. Okay, so we'll cut it here, and then pull out the vein. We call it endoscopic vein harvesting. And this is the cardiopulmonary, this is the heart-lung machine. And this is the bypass, the graph. Let's go to post-op now. Your number one, so here under nursing management. For pre-op, you just need to give the medications and then shower the patient twice. Once the night before, another the day of. Okay, 2 chlorhexidine showers. Chlorhexidine shower as in literally a shower, right? So you wash the patient from head to toe. If they're ambulatory, great. You have them stand in the shower. If they're bedbound, then you do a bed bath. Okay, but either way, right. So chlorhexidine wash will kill everything. Because is this a high-risk procedure? Is this an expensive procedure? Yes. Don't worry, you have all the equipment you need, and these patients are in a hotel style suite. Okay, they won't be in a regular ordinary room. Okay, there's a different suite, dedicated floor for these patients. All right, it's like staying in a Waldorf Astoria, okay, like the Plaza Hotel. Really nice rooms, very clean. They don't put other patients in these rooms, okay? Because these are, again, very expensive. We're talking hundreds of thousands of dollars. So here are your complications during and after surgery: blood loss, bleeding, cardiac tamponade, as we described, or fluid overload because we're giving IV fluids before, during, and after the surgery. And dysrhythmias also, because remember, we stop the heart, right? So when it returns, there may be some dysrhythmias. All right, let's go to the post-op responsibilities. We'll skip the intra-op. I mean, we're not there. Here's post-op. So when they come back, what do we expect again to be attached to the patient? 2 mediastinal tubes and the pacemaker wires, right? Okay. And what will they be wearing in their legs? AT pumps, right? Those sequential compression devices, right? Are they at risk for blood clots? Yeah, these patients are not getting out of bed right away. Okay, so they'll be on bed rest for at least 24 hours. And after that, the next day, we get them out. We sit them in a chair. So watch for strokes, any other cases of embolism. So can they have a pulmonary embolism? Can they have a DVT? Can they have a stroke? Can they have a heart attack? Yes, so watch for all of those. Will they have a urinary catheter? Yes, because we want to monitor early urine output. So that's standard. You want to see if the heart is really working well and if there's adequate cardiac output, as evidenced by how much urine output is the minimum? 0.5 mLs per kilogram per hour or 30 ml per hour. So pain management, we use opioids, okay, IV or PO. And as far as post-op care, it's really nothing different from any other post-op patient, except you have chest tubes and pacemaker wires. And that's it. Just taking a break.